Hello?
Hi, good morning all.
Good
Hi,
morning.
good morning. Okay. So, good morning.
Good morning, doctor.
Good morning, everybody. So
Morning.
today we have the
Good
Cath
morning.
Lab. We have the Cath Lab nightmare series coordinated by Rima. So Rima is here. So Rima, tell us something about today's organization.
So, hello everyone. This is my second session in the series of Cath Lab nightmares. I will talk about a coronary artery perforation. I hope you will enjoy it.
Okay. So you are presenting also this case.
Yes.
Okay. From the next time, it is important that other fellows will present their own case. Okay.
Yes.
So let me know if you have problems or whatever. Can you, all of you, open your cam for a second, please? I would like to take a picture.
I can't because it's dark here, sorry.
Okay, who can?
Bernardo, give me 1 minute, okay? I'm just entering the hotel. So give me 1 minute.
Yeah, no problem. You are already in India, Sandeep?
Yes, I arrived. The flight was 20 minutes late, but okay, I made it on time.
Okay, great. Nice.
When are you coming?
Today is Tuesday. I have the flight tomorrow evening. Yeah, tomorrow evening. Yeah.
Ah, okay.
Tomorrow I
I'll
have
see you
two very
anyway.
long.
But
Yeah?
say again. Tomorrow.
Tomorrow I have two very long CTOs at Academy, so hopefully I will get the plane.
You'll be fine.
So Sarah, what's the time over there? It's 10:30 in the evening? Yeah, okay.
Yes, it is 10:30 p.m. It's still Monday.
Still Monday. Oh, you're late. Come on.
Yes.
And I think Amanda is even worse. It should be something around 3 a.m. or what?
Yes, 3:30. Yes, yes.
3:30. Okay. No, I don't know why you are here. I appreciate a lot, but
Insomnia, I guess. It's a long story.
okay. So now we can start. I would like to take the picture once the other are ready. So okay, when you're ready, you can switch your camera on for a few minutes, so we can do that. Now I would like to start and present again Rima. Rima is coordinator of this activity of DCB Academy, which is Cath Lab Nightmares. Today she is presenting a Cath Lab nightmare actually that she had or somebody else in her Cath Lab had. So I'm asking you to be proactive in interrupting, asking, proposing, provoking, all of that. So this is the philosophy of this type of activities from DCB Academy, all right? So Rima, please.
Thank you. Oh, can I share my screen?
Oh, yes. Okay, now you are allowed.
Thank you. Okay, welcome everyone to the second session of Cath Lab Nightmares. I'll start by my case presentation. Is a 73 years old female with a risk factors of dyslipidemia and smoking, presented with a chief complaint of chest pain with cardiac scintigraphy done and showed ischemia in the inferior segment 3/17, hospitalized for elective coronary angiography. So her cardiac cath was done and showed in the left coronary system there are diffuse infiltrated disease without significant lesions. In the right coronary artery, severely calcified lesion of the mid-RCA segment. And this is her cath. And this is the right coronary artery with severely calcified lesion. And as you can see here, that's here significant mid-RCA lesion. So the operator decided to start the procedure directly. So he started with a predilation using first the balloon.
Okay,
yes.
I'm starting interrupting you, Rima.
Yes.
So you have a positive stress test showing inferior ischemia.
Yeah.
You do the catheterization. I don't know about the left coronary system. How was it?
I don't.
Non-significant.
Yeah.
Okay. So the right was of course significant in terms of person stenosis and highly calcific by the angiography. Yeah. So I would like to ask Antoine, with this case, in your routine case every day, what would you do?
Okay, so was the patient prepared? He was on antiplatelets or?
She was on single antiplatelet, just aspirin.
Okay, so and because it was it was a very calcified lesion, so we start by predilation, and then so I would have done the same.
Okay, so you would start in this case with a predilatation with a trio balloon.
Yeah,
compliant.
Yes, and maybe I will post dilate at a higher diameter.
Okay.
After stenting. Yeah.
I have a comment. So
please,
yes, you can predilate, but if there is an imaging modality, I think probably first thing to see if we can image this lesion.
Yeah, so this is an important point, and this is where I would like to bring all of you. I think that in our job we should evolve ourselves somehow. We cannot do coronary angioplasty like we did. I started back in 2004. I think I did my first angioplasty. We cannot do that. Okay, we should try to evolve. And fortunately, in this job, we have evidence-based medicine, which is quite strong, differently from other categories and other medicine specialization. We have a strong evidence-based medicine, and in the last few years, I would say 2 to 4 years, a lot of data, important data, came out showing the importance of intravascular imaging. I'm not saying that we should use it always. I was at a meeting 3 days ago with Gary Mintz. Gary Mintz is a very experienced physician on intravascular imaging, and he says that they use in Washington 90%. I don't say that because in a daily life 90% is really not feasible, I would say, in a normal cath lab. But we have to select the patients where we should use intravascular imaging, because in these patients mostly it is associated with improved outcome. Clearly, we have a lot of data about that. So we should argue and discuss when we should use this auxilium for our patients. And I think that for highly calcific lesions like this one, this could be a possibility that you should strongly consider. I don't know how the case was. I've not seen that, but just as a comment. Now we lost Rima with her case, so I hope that the case went well. But I know, Sandeep, I think you wanted to say something related to the usefulness of imaging in this type of cases.
Can you hear me?
Yeah, now we can hear you.
Okay, so we should have a balance intravascular imaging. I would not like Gary Mintz or someone who uses 90% of cases, because one is practically possible and financially not viable in most centers. But equally, I'm in a calcified lesion.
No, Sandeep, we have
the most important.
Yeah, we cannot hear you very well.
Okay, hold on. Let me turn off the Wi-Fi here. I think the Wi-Fi is very bad in this hotel. Can you hear me now?
No. Yes.
So I feel that in these kind of cases, the intravascular imaging is very important. For example, as you said, I'm not like Gary Mintz or someone who uses in 90 to 100% of cases, because it's not practically possible because of the financial issues, also the timing and everything. Whereas in these kind of lesions, there is enough data to support that you have to use intravascular imaging. But the most important aspect is that to take the intravascular imaging upfront, because when we say intravascular imaging, a lot of the time people use it after deploying the stent, which is almost waste of time, because by then you would have missed the opportunity to prepare the lesion. So nowadays we should take the intravascular imaging upfront if we can. Maybe if it doesn't go, maybe rotational atherectomy, and then you have to keep repeating the imaging to ensure you have done the adequate damage to the calcium or a plaque before we deploy the stents.
Yeah, this is important. It is important to do it upfront, understand the lesion. And another thing that I would like to stress on is that the imaging is not only useful for finding the correct size of the stent or of the balloon for predilatation. But as you said, it is very important to understand how the calcification is, or how the bifurcation carina is, how the plaque is distributed in a bifurcation lesion. So it is very important to do it upfront. And then it is important also to assess in the end after stenting. But
100%. I think the most important aspect is that once you assess the lesion, then you choose the modality, because if the calcium is deep, like a concentric, and then you have a low threshold to take maybe specialized balloon like a cutting balloon or a IVL. But then after that, you have to repeat the imaging to make sure that you have done the right thing by damaging the calcium before you deploy the stent. I think you made a very good point. It's not
Yeah.
only for sizing the balloon or the stent, but it's important which balloon we choose, like a specialty balloon.
All right, Rima, sorry for this interruption, but we thought that we should focalize the attention on that.
Yes,
Please go
thank
ahead.
I think it's important. It's very important discussion.
Yeah, thank you for your comments. So, as I said, he started to do the predilation with a balloon 3 × 20, and then he increased the diameter of the balloon to the NC balloon 3.5 × 20 millimeter.
Yeah.
Here I don't have directly the image after, because we will understand why.
Okay.
And this is the result after the predilation. So clearly seen.
How much pressure you went up to? Was it AccuForce? Did you say AccuForce?
Up to 20 atmosphere, yeah.
Okay, okay.
Can you let it run? No, again, can you come back,
Yes.
please? Okay.
Excuse me.
Okay, so there is also communication of the. Can you let it run? Let it run constantly. Okay, no, it's too short, but okay, there is also communication through to a cardiac chamber. So okay, this is not, you know, a highly impressive perforation. Of course, you have to fix it as soon as possible. Okay, please.
Before that, I have one question, Rima. Two things I want to ask you. One, is this a 7 French guiding catheter?
We have 2 guiding catheter here. I missed the picture directly before post dilation because the operator did not save the picture directly. So he take this picture after he doing all the steps. So he inserted 2. There is 2 guide
like a ping pong
catheter,
guide.
6 French in the femoral axis and the 6 French in the radial axis.
Okay.
Okay.
So clearly seen it's a coronary artery perforation. I saw this this algorithm very useful in our daily practice in all PCI complications. So if we are suspecting a complication, first question we ask, can the patient perfuse, oxygenate, and ventilate without support for 60 seconds? If the answer is yes, we have to think about the differential diagnosis, what are the reversible causes, and what is the next step. We should ask for help, and we should act. We should enhance cardiac performance, stabilize blood pressure and rhythm, and we should reverse the complication. If our patient is stable, we have to think if it is best for the patient to complete the procedure. If yes, we proceed with the treatment. If not, we should consider optimal post-procedural support. We should stop here and continue pharmacologic treatment, monitoring, and follow-up. If we don't have 60 seconds, here, or the patient is clearly unstable, here the algorithm change. We should act first, so we should stabilize our patient, then we should think, and finally we should ask for help.
Okay.
So what about types of coronary perforations? So there is many classification. According to the location, we have 4 types: main vessel perforation as our case, distal wire perforation, collateral perforation, either septal or epicardial perforation. And then going to the Ellis classification, there are 4 types, and in many references, they talk about 5 types. Type 1, it's an extraluminal crater without extravasation. Type 2, pericardial or myocardial blush without contrast jet extravasation. The type 3, mainly in our case, extravasation through frank, more than 1 millimeter perforation, and the cavity spilling perforation into an anatomic cavity chamber or the coronary sinus, for example.
Yeah.
So likely in our case, it's an Ellis type 3 perforation. And rapidly in this algorithm, type 3 perforation, we should act. So our patient is not stable. We should act with the immediate balloon inflation. We should prepare for pericardiocentesis and for sure starting with the hemodynamic stabilization.
Okay.
Anyone have any question?
No, yeah. So which is the first thing that you did here in this case?
So he inserted the balloon first through the radial approach. Then he do the
Okay.
pericardiocentesis. Then he inserted the femoral guiding catheter and ping pong technique.
Okay, so he had an echo, and
Yes,
there
yes.
was an extra. So it wasn't a chamber.
It was
probably,
a tamponade.
extravasation. There was an extravasation of blood into the pericardium.
Yeah.
So yeah, okay, I see. And this is associated, of course. This is the problem. Okay, if you have a fistula, a iatrogenic fistula, that's not a problem. Okay, you have
Exactly.
time to think. If you have a pericardium tamponade, this is associated with a blood drop and potential fatality for a patient.
Exactly.
As you said, the first thing to do is to inflate a balloon. Okay, then you would stabilize anything and then think. Take your time. Take a second approach. Do pericardiocentesis, whatever. But first of all, inflate the balloon.
Yes, exactly. So patient here was clearly hemodynamically unstable. His blood pressure, her blood pressure is 50/40 and the heart rate 120. So first of all, we did the type and cross match, started IV fluids, and we started with the noradrenaline infusion the time we do the pericardiocentesis. So what are the steps we did here? So first of all, the case is the rupture of mid-RCA or perforation after predilation with an empty balloon, 3.5 times 20, complicated with tamponade. Hemostasis with a balloon track 3.5 times 20, started first, then urgent pericardiocentesis echo-guided with 300 ml blood aspirated, and here the hemodynamics was much stabilized. Then we position a GR4 guiding 6 French via the femoral axis in the ostial RCA using a ping pong technique. And we inserted the covered stent 3.5 times 19 millimeters through the femoral axis in the mid RCA. And finally, we stent the proximal RCA with a synergy stent 3.5 times 38 millimeters.
Okay, so you didn't post-dilate the graft master?
No.
Okay. Of course, you have the angel. You don't have the angels for all of these steps?
I have the final angel.
Okay, only the final one. Okay.
Yeah. So here, the steps of the idea of the ping pong technique, just the idea from this technique, do not lose time. So we insert the second second guiding catheter to insert the stent. The time we withdraw the balloon. So first step, we should do the balloon inflation at the perforation site. We insert the second guiding catheter, and during the insertion of the second guide wire, just we do a little bit short balloon deflation to insert the guide wire. Then we reinflate the balloon, and the time we prepare the covered stent, we directly deflate the balloon, and we insert the covered stent in the perforation site, at the perforation site.
Yeah, probably the deflated balloon should come back into the guiding catheter, because otherwise sometimes the covered stent is not crossing the proximal part of the vessel, because it was a highly calcific vessel. So you retrieve it a little bit more into the guiding catheter, the blue guiding catheter, and then you can advance the covered stent.
Yeah, exactly. So here I will explain just what we are doing here. Then first, this is a GR4 radial approach, through the radial approach here, and the first guide wire. Here the balloon prepared, he did the deflation just to insert the covered stent. Here the pericardiocentesis catheter, the two wires, and the GR4 femoral approach. This is the second one. So here We see the covered stent at the site of perforation, and the second stent in the proximal part of the artery. And this is the final result after stabilizing the patient.
Okay. Good. Patient here was okay. Blood pressure was
Blood
higher,
pressure
I think.
was okay. Yeah. After the pericardiocentesis was stable, and here the hemodynamics all are stable.
Okay.
So here a nice algorithm for
Too
management.
complex. Too
Yeah.
complex. Too long.
I know, but it's very important because when we have a main vessel perforation, we should ask ourselves if the patient is hemodynamically stable, yes or not. If he is stable, so we have to think if the wire is across already. We did directly the balloon tamponade. If we have severe perforation or Ellis type 3 or active extravasation, we should insert the covered stent and do the protamine after. If
This is an important point. So you did protamine here?
no.
Okay, yeah, because protamine, it's may have some drawbacks. If you give protamine, then you implant a covered stent, which is a highly thrombogenic device, and then another long stent, and you work with an ACT of around, I would say, 150, 160. That's very risky for acute stent thrombosis.
Yeah.
Not only that, there's another problem with the protamine. It will make your pericardial effusion into a jelly. So it will be very difficult to aspirate it. So I always never give protamine in this situation because we have to fix the mechanical issue. Moment you give protamine, you're risking stent thrombosis, as Bernardo mentioned, but also you risk the formation of a jelly in the pericardium, which will be difficult to take it out.
Yeah. Yeah, at this stage, I think that they already removed all of the blood that they had to remove. This was clearly not an issue of perforation related to a high ACT or too much heparin. It was a mechanical perforation related to a technical mistake. Yeah. But so you did a good job in not doing a protamine here also. Okay.
Okay, so if the severe perforation, the perforation is not severe, but your patient is still bleeding, here you should do covered stent. If not, you should stop the procedure and consider protamine another time and support as needed. If our patient is you try to wire the perforated vessel and it's not successful, you should do balloon tamponade as proximal as you can to perforation. You send patient for cabbage. You can do coils, or you can enter the subintimal space to seal with dissection. And of course, if your patient is unstable, you go directly for stabilizing your patient with IV fluids, pericardiocentesis, type and cross. You can do transfusion or auto-transfusion from the pericardial blood, and you should notify your cardiothoracic surgeon.
Okay.
Same for the distal vessel and collateral perforation. Just I have 2 to 3 slides. If your patient is stable, for sure you go for balloon tamponade, also proximal to the perforation. If you are not successful, if you are successful, you stop the procedure. If not, you should you may inject thrombin, fat, or microspheres, or you do occlusion of a branch with covered stent, even if it is distal. You can do suction via microcatheter coils, or anterograde and retrograde occlusion may be required. If your patient is unstable, same, you should stabilize your patient with IV fluids, pericardiocentesis, and so on. So as take-home messages from this case, we should know our patient well. We should respect the anatomy. We should never underestimate any calcified lesion. Perforation can occur following subsequent lesion preparation. We should prepare always for the worst. And we should anticipate and prepare for rescue measure of perforation in the Cath Lab. Immediate balloon tamponade should be the first rescue by times for planning and reassessment. Perfusion balloon is a good idea. I don't know if you use it.
No,
First
nobody
time
uses
I read about it. If available, maybe consider for tamponade. And this is the perfusion balloon. This
Yeah.
is the
I don't
one
know if it does exist. Is anybody aware of a perfusion balloon being in the market?
It's
I'm
available
not aware.
in Asia, in Malaysia, those places, but not in Europe.
Okay.
In this occasion, I will show you just a recent article, but I did not read it all. They talk about stentless strategy with perfusion and drug-coated balloon in acute coronary syndrome. So they use the perfusion balloon just to make a long efflation with long time, up to 30 minutes, and then they use the drug-coated balloon. I don't know if it's usable.
Yeah, okay. Yeah, it's a possibility, but here, the drug-coated balloon may have a sense if you use a covered stent. Covered stent is not medicated by drugs and is associated with higher risk of stenosis and thrombosis. So it could make sense to use a DCB upfront. So in this case, yes, but when you put a flow chart or a reference to any study, Rima, please put the name and the article and the journal and the year, a minimum, okay, just to understand where it was
2023, I will
published.
send it to the group.
All right, thanks. All of these flow charts, it's interesting to see because in a previous flow chart, I saw somewhere bare metal stent, so probably it's not very updated flow chart, just to understand. Okay.
Yeah, I will send it.
Yeah. So I think that this case was managed very well in terms of life saving for the patient, because I would say, okay, there is no direct rule, but the decision of the operator is of paramount importance in deciding each step. So there is not a law in our job, okay? So I think that what he did it correctly, and in the end, he saved the life of the patient. Among the take-home messages, I would say that you forgot to mention the most important one, which is to correctly address the calcific lesion. So you don't not only have to respect it, but you have to understand it to treat it correctly. So in this case, I can hypothesize that there was a calcific nodule, maybe, we will never know, that was compressed by a high pressure and a high diameter balloon versus the external part of the vessel, creating the perforation. If you did intravascular imaging, probably you would have avoided this. So this is why intravascular imaging in these cases is so important, because you can avoid complications and you can reduce death. Because out of 100 of these perforations, I would say that some patients could die. Cannot say if 2 or 5 or 6, but mortality in this case can be high, also because of, as I said, thrombosis of the covered stent and all of that. So it is very important to understand the lesions, especially in an elective case.
Yeah.
So I would like to ask for comments also by Leo, Dr. Krupal, Sarah, Amanda. Amanda, are you sleeping?
Hi. Hi, can you hear me?
Yes.
I
Who is
have
this,
a
Leo?
short Leo, yeah.
Yeah.
I have some short comments in the question. First of all, nice solve of the case, but I saw that you pre-dilated with the active force, and then for the ping pong technique, the balloon was a mini thread. So I assume you didn't have the balloon in the guiding catheter when you saw the perforation, right?
Can you repeat the question, please?
I saw that for pre-dilatation, you used the Accuforce, and after you saw the perforation, you used a mini track for stopping the perforation, the bleeding.
Yeah.
So I assume you didn't have the balloon on the catheter when you saw the perforation.
No, yeah, exactly. This is what,
Yeah,
what I meant. I
yeah,
didn't have the image because he saw the perforation and directly he act with reinserting the balloon because
yeah.
he
I
withdraw
in
the
this
balloon.
situation, I was asking. I usually have. I usually use a direct stenting with a graft stent. I don't know if you always use the ping pong technique, but when you take another balloon, if you don't already have it on the catheter and you put it in a few seconds, it's almost the same time as you would use the direct stenting.
I think that's a good point you made, Liu. See, the thing is that I have a very low threshold now to use 7 French guiding catheter for any calcified lesions, unless patient can't take it. The advantage of using a 7 French guide is that you don't need a ping pong. So, for example, if I have a wire and let's say I perforate with the balloon, I always check the like a test shot before you take the balloon out of the guiding catheter. So if you
Exactly
identify
that.
perforation, you put the balloon back straight in, and you inflate at like 8 to 10 atmosphere to stop the blood flow. Then you take a second wire and you bring it near the balloon, deflate the balloon, put the wire, then inflate the balloon again. Then you take the covered stent on the second wire and you bring the covered stent very close to the balloon, then deflate, put the covered stent, pull the balloon back, and then deploy. So which means you don't need ping pong. Everything can be done in one access with the 7 French.
This is also my daily routine. I usually use 7 French for highly calcified lesions, and I always check with a mini flash after each inflation.
Yeah, it's very important.
Leo, so I didn't remember when you used to work at my Cath Lab that you did these perforations every day. But I think that we should speak about that.
I didn't do any perforation 4 years ago.
No, never. Yeah. That time, yes, but after 4 years, who knows? But okay, never say that because it's also bad luck. Okay, that's good. Just joking. Okay, any other comment?
Everyone will have perforation, so it is a part of the
Of course.
procedure. So it is something which should not be.
The problem with complications, Sandeep, is that at least in my experience, you have a series of perforation in a certain periods of life. It may happen that for 2 years you don't have complications, and then they start, and they're very close, and that's very nasty, I would say.
It also dents
the
confidence. It also dents the confidence of the operator.
Yeah.
You see, the thing is that there are two more points, if that's okay if I make. One is that you made a very good point. If you use the intravascular imaging, now I have a very low threshold of taking a IVL balloon, because IVL balloon you never go beyond 4, especially if it's 1-to-1. So the advantage of IVL balloon is that you get a same cracks or maybe even deeper cracks with a very low pressure inflation, unlike OPN or AccuForce, where you have to go up to 20, 30, 40 atmosphere, which is completely crazy. We don't know what's going to happen to the artery. As with IVL, you tend to get like a radial force of the shock wave going deep into the adventitia with calcium. So I think nowadays we have a very low threshold of taking IVL balloon, especially the calcium is deep and severe.
Yeah, I agree.
Hello, good morning. I would like to share my shortly share my experience about the perforation and calcified lesion and the IVL. First of all, Rima, I would like to congratulate your case. And a few years ago, I have a case calcified case, and after the predilatation with the NC balloon, I had a perforation. It was also RCA, and I put a stent graft inside the artery, but unfortunately the calcified nodules modulated all the time the stent graft, and it was underexpanded. So I put IVL inside the stent graft, and I did IVL inside the stent graft, and it was effective and successful, and there is any other complication after that, and in long-term follow-up also. So it's my experience that after
Nice.
implantation, it's also possible to do the IVL to optimize the procedure.
Yeah. Yeah, we are still saying something that we should use it up front. Because we have used IVL just after stenting, several times, but we should think that this should be just not used routinely, but we have made some mistake, of course, of serious different grades of mistakes if we use it after stenting. IVL was developed and invented for lesion preparation, only for that. So this is very important to understand that the first thing is to understand the lesion that you're facing. And I think that in this type of lesions, as we said, like in big bifurcations, left main and ISR, now intravascular imaging is of paramount importance.
Yes,
I think this is the key message.
Yeah, I agree, and I think that the procedure are more predictable with modification of the calcium before, of course, the stent implantation, more safe. So, of course, I agree. Thank you.
Yeah. All right. Any other comment on this?
Sir, yeah. I'm Dr. Kripal.
Yeah.
So in this case, isn't the balloon size was quite big, like 3 mm balloon? Preparation with 3 mm balloon is quite big balloon, like they should have used 2.5 or something, or 2.75.
But you mean in a stepwise dilatation or as a final balloon before stenting, in this case?
Like for pre-dilatation, like.
So you would have used a smaller balloon, but still a larger stent, a 3.0 or 3.5, I think, no?
Yeah, like 1-to-1 balloon sizes, sometimes it causes dissection, like 0.25 lesser is better, actually.
It depends on which is the final treatment that you want to achieve. If you predilate with an undersized balloon in this highly calcific lesion, and then you decide to put a stent, the stent would probably become not well expanded here. I'm pretty sure about that. So if you decide to use a smaller balloon and then increase it, it's another strategy to crack the plaque in a different way. Still not adequate for the case, because I think that in this case you would have used any other, orbital or rota or IVL up front. But that's a different strategy. In this specific case, I think that the operator was in a hurry. He was in a hurry. So he started with a 3.0 balloon, then a 3.5, then he had a perforation. When we deal with calcium, we have to respect it, like in any other type of lesions, but not, shouldn't be in a hurry.
Yes. But this was a very good save, actually, like probably like type 3 perforation is like immediate death, actually. But it's really nicely saved.
All right. So, other questions? No? Yes? Okay. That's fine. I would like to thank again Rima for the very nice case and very didactical one, open to a lot of nice discussions here. We have the next lesson. I don't have here the list of it.
March
program.
5th.
March
5th. 5 of March, yeah.
5th of March.
Next
right.
Tuesday. By
So,
Dr.
and it will
Wojciech.
be, okay, how to treat under-expanded stent. Okay, great.
Yes.
And then we can, after that lesson, we can discuss about the status of our papers, okay? And next lesson will be at 5 p.m.
Okay.
Okay? All right. So thank you again. Have a nice day.
I think Dr. Sandeep.
Have a nice night. Yeah?
Thank you.
Sandeep?
Dr. Sandeep has a case to present.
Today?
No, maybe it's like the other day for the
okay.
for
Well,
the
next complication.
Okay.
No, the other activity.
The one with the
That we
Sarah
have,
doing it.
Yes, my
The Sarah
activity.
activity.
We have Dr. Sandeep and Dr. Wojciech as a moderator.
All
Yeah,
right.
yeah, I've got the case ready, no problem.
But this will be
Thank
critical
you.
thinking, and it will be March the 12th.
Yes,
Yes.
exactly.
All right. At 1
Okay.
p.m. I hope I can make it because I will be in the US, but anyhow, I will let you know. But
Okay,
this is,
everyone, thank
for
you
the
so
moment,
much.
is confirmed. Yeah. Thanks a
Thank
lot,
Thank you,
guys.
everyone.
Have a nice day or night.
Thank you.
Bye-bye.
Thank you, everyone. Have a nice
Bye.
presentation, Rima. Congratulations. Bye, bye, bye.